We shall now go on to our next speaker, who is the founder and director of Future Vision Eye Care and Research Center based in Mumbai. And we have Dr. SABYASACHI SENGUPTA, who is going to be presenting on a case of nodular scleritis. On to you. Have you to...
Sorry, I'll just share my screen again.
Yeah.
Very good evening to everyone. So I'll share an interesting case. We don't have a lot of time. So this was a 35-year-old lady. She had defective vision and pain in her left eye since the past 3 days. Otherwise, she was systemically healthy and she had no other complaints. This was the photograph of the right eye, which is the normal eye. As you can see, there are some little bit of RP alterations, but nothing much to ponder on. This is the image of the left eye, which she had decreased vision. As you can see, these are some striae. There is some fluid here, and noticeably, you can see a very large subretinal fibrinous lesion, which is also elevated. So, this is obviously the cause of decreased vision. So, differentials for a subretinal sort of fibrinous lesion with fluid are, a very large fibrinous central serous chorioretinopathy, or sometimes subretinal or choroidal abscess can present like this. An atypical VKH could also present like this. Posterior scleritis and amelanotic melanoma are some of the lesions that you might think about when you see a lesion like this. So we went ahead and did some imaging, which led us to the diagnosis. I won't present too much of all the investigations, but this was the red-free image. As you can also see these striae very nicely here. This is the the mid phase of the fluorescein angiography. So the arteries are filled and the veins still have some laminar flow. You can't really see much happening as yet, except for the defocus because of the elevated lesion. And this is the late phase. As you can see, these are some pinpoint leaks, which is at the periphery of the lesion. There is some amount of staining which is happening here. These are some window defects because of RP alterations. So this is the much delayed phase where the image was taken after 10 minutes. That is post recirculation, or so you can see this pooling of dye, and there is staining, which as you can clearly see here. So this is much deep, and the staining is very clearly seen at a very late phase. And this is the ultrasound B scan. It's not very clear, but you can clearly see a very thickened RCS complex with subtenon's fluid, which gives away the diagnosis of posterior scleritis. And this very large kind of presenting lesion is known as giant nodular posterior scleritis. This is just to compare. This is how a melanotic melanoma would look like on ultrasound. So we went ahead and gave her high-dose oral steroids at 1 milligram per kilogram of oral prednisolone, and then that was tapered. This is at 1 week, and this is at this is at 1 month. So as you can see, it's almost as if nothing has happened there. So it's really melted away very nicely. Vision has, of course, come back to 6/6. This is how a regular case of posterior scleritis would look like, where you will still see some striae and some fluid at the posterior pole, and some amount of edema. And usually the disc will be quite hot, or in inflammatory lesions. And again, you will see this kind of starry sky appearance. Some other mimics that I had that I wanted to show is, so this is another case where you can see a very large fluid here, almost at the same place as the previous case, and there is some fibrin which is less than the previous one, but still you could almost confuse it for one another. And this is a angiography which clearly shows a very large ink blot appearance. So so this is the lesion of the posterior scleritis, and this is CSR, fibrinous CSR, which could sometimes mimic that way. This is just an image of a very large amelanotic melanoma. So even if it's amelanotic, it will still be slightly grayish. So this is the montage of that same patient. So of the same patient of melanoma. So so these are some mimics of giant nodular posterior scleritis that I thought I'll discuss and show you the case of posterior scleritis. So that's it from me.
Very interesting, Dr. SABYASACHI. And can we have Dr. Malika discussing this interesting case?
Yes, Dr. SENGUPTA, and the idea is that it will highlight the various differentials. And posterior scleritis is definitely one of the most underdiagnosed conditions because it mimics so many conditions. In this case, I would say that the presence of a young lady, sudden onset pain would not be seen in CSR or even in metastasis, choroidal melanoma, even VKH maybe. And then if you had VKH or choroidal abscess, endogenous ENDOF can present with exudative RD, you would see some cells in the vitreous and AC, which you didn't see. So I think any patient who has pain, sudden onset pain, young lady or any age lady, in fact, our first mind should go to scleritis, which we often miss. And there could be some congestion of the conjunctiva. I don't know whether it was there in this case. Was there any congestion of the anterior?
So, ma'am, this anterior segment was completely quiet, and she had actually received some NSAIDs from a local physician. And so she didn't actually complain of pain, but we had to elicit that history that there was significant pain at onset. And then, that's how it went. But the anterior segment was quiet.
Now, I was wondering if you had done OCT, because OCT would also be a very important, it would show some choroidal elevation in the case of a scleritis, whereas it would not show in CSR or other conditions. So did you have OCT for her?
I don't have those images actually with me, but it was done. Serial OCTs were done, and that showed, a very large elevation. And yes.
Yeah, that's very important. And the angiogram also was ruling out a lot of other differentials. The other differential can be leukemia. It can present with infiltrates like this, but your angiogram was not supporting leukemia, lymphoma, where you get a punctate hyperfluorescence. Even VKH or sympathetic ophthalmia, you would get punctate hyperfluorescence. So and certainly the FFA ruled out CSR. So I think all in all, it's a good case, and clinically itself, we can make out a lot of differential, and so good case.
So also one thing is, if we do an angiogram in these cases and looking at scleritis, the significant finding is staining at very late phases. So, that area of scleritis was stained very nicely, almost at 10 minutes post the scan. So, that was something additional that people would want to remember.
How do you clinically differentiate these cases based on the color, posterior scleritis, based on the color of lesion?
No. See, here there was a large nodular mass obvious under the retina. So that automatically rules out CSR. A bullous CSR will not have that kind of nodular lesion, and pain would not be there. But not from the color, Dr. Chitra, because even metastasis can be this color. Even amelanotic melanoma can be this color. VKH could also have this kind of exudation. Choroidal abscess has this kind of tuberculoma. A subretinal tuberculoma with exudative RD would have the same color. So probably not the color, but the associated features.
Yeah, I think the greatest feature was the striae that you see, basically showing that there's a mass lesion. And I think the ultrasound is one of the best tools to diagnose this than anything else. You cannot miss on ultrasound. The reason you said that there is a hot disk is generally because posterior scleritis is a little more diffuse. So you get a hot disk. In nodular posterior scleritis, you would probably not get it. That's the difference why you would have had some of the features.
Right.
Srinivas?
Guru sir, you have any the comments on this, or any expert panel would like to tell on the angiographic findings? How would be different, because we were mimicking with the amelanotic melanoma as compared to the posterior scleritis. Will the angiography itself would have been picked it pretty early, differentiating the two rather than having the confusing amongst the two diseases?
I think this was a very typical case. There was nothing atypical in this case. I think one would straight away make a diagnosis of scleritis, but this nodular scleritis is something that we don't see very often. I think that was good that Dr. SABYASACHI presented this case in this seminar. About the angiography, I think if it is an amelanotic melanoma, there will be a double circulation seen, which is not seen in nodular scleritis. I think that's all the difference between the two. I think that's all from my side. Yeah.
Scleritis, you may have nothing on FFA. In a normal scleritis, the FFA may look completely normal, or there may be some subtle punctate hyperfluorescence or a hot disc, but there may be nothing.
But Srinivas, I would not probably think of fluorescein angiography to make a difference. Ultrasound gives you both differentiates amelanotic melanoma and posterior scleritis very well. I would probably rely on ultrasound than in fluorescein angiogram.
In fact, I would suggest that any patient presenting with pain, take them to the B scan before you say there is nothing or not, even if the fundus is normal. You'll be surprised at the number of patients you'll pick up with choroidal thickening and retrobulbar fluid, retroscleral fluid. You'll be surprised. And they get so much relief from your treatment for the scleritis, which is missed.
Thank you very much, Dr.
It was a wonderful case, Dr. SABYASACHI, where in 1 week he showed how quickly it responds to the steroids. I think that was
So actually, so first thing we did was ultrasound, and we were quite sure it is scleritis, and that's why the angiography, which was done a few days later, we delayed and took an image at 10 minutes, which you would generally not do. So ultrasound was sort of the clincher.
Thank you very much, Dr. Sabyasachi, and thanks a lot, Dr. Malika and Srinivas and